Is my screen visible?
Now it's visible. Yes.
Good evening, everyone. We welcome you all to the insightful webinar of monthly online meeting by Maternal Fetal Medicine and Genetic Academic MFMG Group Educational Series. I, Soumya, on behalf of Strand Life Sciences, one of the oldest genetic companies in India, founded in 2002, we are committed to delivering quality with affordability. Our entire product line, including NIPS, matricic, exome sequencing, which detects both copy number variation and SNVs, advanced chromosomal analysis testing through SNSIC, and comprehensive coupled carrier screening for 2000 gene is performed on the most advanced Illumina NovaSeq X Plus platform, ensuring the fastest turnover time available. This session is always very interactive, led by Dr. Deepika Deka. She is professor and head of unit chief, maternal fetal medicine division, Department of
Was.
Obstetric and Gynecology, AIMS, Delhi. She was director, AIMS, Kalyani, Kolkata. She was vice chancellor of Health University, Government of Assam, and first lady vice chancellor in Assam or other
Yeah,
among
we can
FOG
stop
Assam
here. I'll
region.
take over from here.
Yes, welcome to the session, everyone. And dear ma'am, I would request you to take the session.
ठीक है. Thank you. Please. Yeah. I would first, can we see this slide?
Yes,
So
ma'am.
Yes, ma'am.
actually, Dr. Manju, I kept on asking you for your latest biodata. Couldn't get it, but I have to say that she is a very well-known senior consultant obs gynae in Delhi. She was a senior resident at AIMS, and after that, she was a faculty and professor at Lady Harding, and now she's into her practice. Welcome, Dr. Manju.
Thank you.
So we have Dr. Vandana Gupta, who is the president of the Delhi Gynae Forum, which I talked about in the East. She's a gold medalist in MS, and she has a host of awards and accolades. And she's a very, very active member. She's a senior consultant in Max Hospital, Patparganj, Lifeline Hospital, RK Hospital, Epic City Hospital. And you can see her special interests on the slide. Dr. Suchita Nanda, she's a senior consultant radiology and she's a trained fetal medicine specialist working in global ultrasound, Dwarka. So it is my
Thank you.
pleasure to introduce Dr. Bijoy Balakrishnan, who is a gynecologist, and he's the chief consultant in fetal medicine at CIMAR since 2007. It is the first fetal medicine unit of Kerala. So he's an obstetrician gynecologist and is trained in fetal medicine and 3-4 ultrasound and fetoscopy. So it is my pleasure to invite you, Dr. Bijoy Balakrishnan. He has been actively, delivering lectures all over the country, abroad, and I am very happy that he has agreed to deliver this talk on the management of twins, especially FGR. Thank you, Dr. Bijoy.
Thank you, ma'am. Thank you. Shall I share my screen before we start? Yes?
Yes, please. Yes, please.
I hope my screen is visible. Yes?
Yes.
Yeah. Okay. Good evening, everyone, and thank you, ma'am, for the opportunity to be here. Over the next 40 minutes or so, I'm going to try to bring some light on this very complicated topic, FGR and twins. When we talk about twins, we always try to approach it as good news, right? It's good to have two babies in a go, and then you can finally forget about pregnancy in future and just be happy with twins. But as far as obstetricians are concerned and fetal medicine people actually find it a difficult job to manage twins, especially when there is growth restriction. And I'm going to just talk about that subset. There is a huge group of problems that are attached to twins apart from growth restriction, but I'm going to just talk about growth restriction. When we talk about growth restriction in singletons, it's always a balance between when do you deliver this baby. It's about timing the delivery at the right point so that the baby does not come out too asphyxiated, the baby survives in the NICU, and at the same time, you're worried about the mother as well. So in singleton, it's basically a tussle between the mother and the fetus, and to get the timing of your delivery exactly right. But when it comes to twins, there is one another person that we have to be worried about, and that's the AGA fetus. Now, when we time our delivery for the sake of the smaller twin, there is a possibility that we might be putting the normal growing fetus at risk. And into that complex, if you add monochorionicity, you're going to further create problems, because you know that if one baby dies inside the uterus, there is a good chance that the normal growing fetus could also die or succumb from neurological damage. So we're trying to find out a solution to this problem. How do you manage a small baby in the setting of both monochorionicity and dichorionicity, and how to actually find the correct way forward? But first things first, the first thing that we need to address is, how do you assess smallness? How do you assess smallness in twins? And this is a very big problem, because we know that twins are basically smaller than their singleton counterparts. Whenever you compare twin fetuses, you would find that they are lighter than their singletons by almost around 1 kilogram at term. And even if you correct for their gestational age, you would find that these babies are smaller. And Gardozzi, way back in 2005, said that probably twins have a different growth pattern, and that 37 weeks would be equivalent to 40 weeks for a twin pregnancy, and therefore these twin babies might be smaller. But the problem here is that physiological, or is that a part of a pathological process? Because if you assume that smallness in twin pregnancy is a physiological process, then shouldn't the perinatal outcomes be comparable to that of singletons? But when you compare the perinatal outcomes of singletons and twin pregnancies, you would find that the perinatal outcome of multiple pregnancies is far inferior when you compare it to singletons. And the largest study that has been done to look at this problem was the Stock study. And the Stock study said that yes, it would be useful to use twin specific charts, but in that paper they clearly mentioned that if you're using Doppler along with growth, then the utility of using singleton charts are not, twin specific charts are not very significant, which means that it would be better to use a singleton chart, and at the same time use Doppler whenever you're using a growth scan. Whenever you're doing a growth scan, do a Doppler study as well, because that way the chance of missing out on FGR is highly unlikely, and you would probably be able to pick out those fetuses that would need a little bit more closer surveillance. The second problem that we should be worried about is discordance. When one baby is smaller than the other, here we use the larger twin as a benchmark for the growth of the smaller twin. And when we find that the discordance is above 25%, that is when we are going to be worried about possible poor perinatal outcomes. But here we should understand that this discordance of 25% can also vary with gestational age. For example, at around 20 weeks, even a discordance of about 20% is going to be significant. And therefore, it's important to understand that although we say 25%, whenever the discordance goes beyond 20%, we would still be a little bit more careful while looking at these twin pregnancies. Now, once we have got that out of the way, we understand that we need to look at singleton charts. We understand the importance of looking at discordance. Let's proceed further to different types of twins. Let's start off with dichorionic twins. In dichorionic twins, the reason for smallness is a bad placenta, as obviously for singletons also. When one baby is small as compared to the other in a dichorionic pregnancy, you would probably suspect that the placenta is bad, and you're looking at uteroplacental insufficiency for that particular fetus. And we do get markers for this by looking at the first trimester CRL, because whenever we find that there is a discordance in CRL, we are slightly worried as to the possibility of these fetuses developing growth discordance and FGR later on. But at the same time, we should understand that dichorionic pregnancies could be dizygotic or monozygotic, and the dizygotic ones could have differing genetic potentials as well, and therefore it need not always be FGR which leads to a difference in CRL in the first trimester. But the first thing that you look for when you find a CRL discordance is anomalies. And if anomalies are not present, then alone will you start thinking about different genetic potentials or fetal growth restriction. Let me give you an example of a case here. Two fetuses A and B, obviously B is smaller than A, and a cursory glance of B, the smaller fetus, does not show anything actually. You find that the baby is looking fine, the CRL looks pretty okay, it's just small. But when you look at it a little bit more closely, you would find that the heart has got an abnormality with a single outflow tract that is coming out from the anterior chamber. And when we look closely into the nuchal translucency plane, you would find that the IT is significantly dilated, and closer inspection tells us that we are looking at a small encephalocele. So difference in CRL should always point towards anomalies first, and if no anomalies are present, then we think about growth restriction and differing genetic potentials. But whenever the CRL discordance is seen in the first trimester without abnormalities or anomalies, you should understand that there is a high chance, around twofold increased risk of having discordance at birth and delivery before 34 weeks. After that, we proceed into the second trimester, and in the second trimester, we do serial ultrasound scans at monthly intervals. And whenever you do a scan, you should follow it up with a Doppler scan as well. So you do a growth and Doppler in each visit, and you would make the diagnosis of FGR based on the Delphi consensus criteria. If you have any one of these fetuses less than the third centile, automatically you would classify them as FGR. On the other hand, if you have a combination of either two of these three contributory criteria, which is an estimated fetal weight less than the 10th centile with or without discordance, or even it can happen just with discordance and an umbilical artery abnormality. So it need not be that these babies are less than the 10th centile. They could both be well above the 10th centile, but if there is a discordance and an umbilical artery abnormality, then you would still classify them as FGR. So there are three types of SGA fetuses that you could get. One where you have one normal fetus and the other one being small, which is by far the commonest. You could have both babies being small. You could have discordance with no smallness at all. And the best method to actually see that or make that diagnosis would be to use a growth chart. So when you use this growth chart, you can obviously say that, okay, these babies are growing with concordance and are not small. And if you look at this chart, you can say that there is discordance, but the A baby is not very small. And here you can see that there is discordance with severe smallness. So whenever you're doing a growth scan, it's important to look at the growth chart, see their difference, so that you have a visual aid to tell you that you're looking at discordance along with smallness. Now, as far as dichorionic pregnancies are concerned, we are not worried about single intrauterine fetal demise, because even if one baby dies, it does not put the other fetus at risk because they do not share a placenta. And the risk of DIC, which was actually a thing of concern in the past, has been clearly shown to have no effect on the mother or the fetus. And the only risk that you would probably have here is that of prematurity. Now comes the question, you have FGR, how do you manage these fetuses? The common wrongly given advice is to manage them as singletons. This can't be more far from the truth, because in singletons, we don't have to worry about the AGA fetus. We just need to worry about the singleton that is small. So here the dilemma is, when you decide to deliver, do you decide to deliver based on the smaller fetus, or do you decide to deliver based on the larger fetus? Now, if you decide to deliver based on the smaller fetus, you would put the larger fetus at risk of prematurity. And on the other hand, if you decide to deliver based on the larger fetus, you risk the smaller baby's demise. And even worse, you could probably land up with a handicapped fetus because of severe fetal compromise inside the uterus. Now, this question was settled once and for all by this paper. It's a pretty old paper, which is the only prospective study which has been done so far. And after that, they did not have to do it, because this actually settled the question once and for all on when to deliver DC pregnancies with one baby that is small. So what they did in their cohort was that they prospectively followed up fetuses with growth discordance, and they did not do anything till around 32 weeks. Till 32 weeks, they decided that they would not touch these fetuses and would allow them to grow irrespective of what happens to the smaller fetus, and then deliver them at 32 weeks based on the condition of the smaller fetus, understanding that the smaller fetus could die by the time that they reach 32 weeks. And what they found in their paper was that 35% of those small babies did die. Almost all the AGA babies survived except for the two that went into preterm labor, but that was not connected to the growth discordance. And one IUGR fetus survived with handicap. Now, this was way back, probably in the 90s, and now things have changed a little bit more. But before we understand when to deliver, let's look at the alternative. What would happen if we decide to deliver based on the condition of the smaller baby? Because you say that you want to save the smaller baby as well, and let us try to deliver based on the smaller baby because we have got very good NICUs. Why not deliver based on the smaller baby? When you do that, and if you decide to deliver based on the smaller baby, you are increasing the risk of demise for the larger baby. Only 40% of those babies are going to survive. And out of those 40%, 25% of them would have severe handicap. And the baby that you're trying to save, the smaller baby, yes, you would save them. 70% of them would survive. But of those 70% that survive, 70% would have severe handicap, which means you're not doing any good by deciding to deliver based on the smaller baby. But does that mean we wait till 32 weeks without doing anything? And that's where this chart comes into play, where we look at the increased risk of major complications and with respect to prematurity, and you would find that the risk of major complications and neonatal death keeps on decreasing and is the least at around 31 weeks. By around 31 weeks, the chance of fetal demise or neonatal death is almost zero, and the chance of major complications keeps on decreasing and becomes zero by around 34 weeks. So if you take a 30 weeks cutoff, the chance of having developmental delay or cerebral palsy are going to be very, very less. And that is why currently the recommendation is to wait till 30 weeks in a DC pregnancy with one baby being small and not do anything till 30 weeks. And after 30 weeks, you decide to do your delivery based on the condition of the smaller twin. So when you're deciding to deliver based on the smaller twin, you would use the same targets that you would use in singleton pregnancies. You would look for DV reversal, and if DV is reversing at or beyond 30 weeks, you would deliver. 30 to 32 weeks if you have reversed end diastolic flow in the umbilical artery, 32 to 34 if you have an absent end diastolic flow within the umbilical artery. The same criteria that you would have used in singletons, and of course you would have to start looking at the CTG and the biophysical profile from 30 weeks. Now, if none of these triggers are hit, you would deliver them electively by 36 weeks. So the trigger for delivery has to be the condition of the smaller baby after 30 weeks and not before that. Now, there is another entity in growth restriction in dichorionic twins as well, which is called as late onset growth restriction in DC twins. Now, this is similar to late onset growth restriction in singletons in the sense that one baby is going to become small after 32 weeks. But here we are not very worried about prematurity because this smallness is happening after 32 weeks and we can comfortably deliver them by around 36 to 37 weeks. To sum up about dichorionic pregnancies, whenever we see CRL discordance, look for anomalies. After you have ruled out anomalies, think about differing genetic potentials and also think about the possibility of growth restriction. Do your serial growth scans at monthly intervals along with Doppler. Whenever the discordance goes beyond 25%, understand that there is a risk of poor outcomes. Do nothing till 30 weeks, that is, go for expectant management till 30 weeks. Of course, you have to keep a close watch on the mother's hypertensive status because these mothers could develop preeclampsia. If that does not happen, take them till 30 weeks. After 30 weeks, deliver based on the condition of the smaller twin using the same singleton criteria that all of you are aware of. And in the process, if one baby dies, it is not an indication for preterm delivery. Take this baby to term if one baby dies. And that's about dichorionic pregnancies. What about monochorionic twins? Now, the problem with monochorionic twins is that nobody knows exactly what to do in these fetuses. The RCOG guidelines have clearly stated that there isn't enough high quality evidence to actually tell us on how to manage these pregnancies. Whatever we have is based on systematic review and meta-analysis of various studies that have been done, small studies that have been done across the world. Now, the problem in monochorionic pregnancies is the fact that the placenta is not equally shared. This is a good placenta. Why do I say good placenta? Because one baby is growing well with the help of that same placenta. So the placenta is absolutely normal. The problem is unequal sharing. So the basic difference between a monochorionic placenta with FGR and a dichorionic pregnancy with FGR is that in dichorionic pregnancies you have placental dysfunction, whereas in monochorionic pregnancies you have unequal placental sharing, and on top of that you have another problem, that is vascular communications running between one fetus to the other. So here this is a problem of sharing rather than an abnormality in the placenta. Now this is compounded by the anastomosis that run across the placenta. Now what's happening in the placenta in a monochorionic pregnancy is that there are two kinds of anastomosis, a deep anastomosis and a superficial anastomosis. A deep anastomosis is an arteriovenous anastomosis which runs within the cotyledons of the placenta and takes blood from one fetus to the other. You're going to get unidirectional blood flow from one side to the other. And this is primarily the reason why you get the most dreaded complication in monochorionics, that is TTTS. On the other hand, superficial anastomosis are similar vessels that run across the surface of the placenta, which means you will have an arterioarterial or a veno-venous anastomosis that runs across the surface of the placenta, and the flow across these channels or these vessels are going to be bidirectional. And when I say bidirectional, it means that blood can go from one side to the other and come back from the other side to the first side itself. Now, this blood flow is governed by blood volume and pressure differences across these two fetuses. So, if one fetus has larger blood volume, blood will flow from that fetus to the other side. And if there are pressure differences, for example, if one baby has a sudden hypotension or sudden bradycardia, then pressure on that side will decrease and blood will flow from the opposite side to the side which has got decreased blood pressure. So an arterioarterial or a veno-venous anastomosis, the blood flow is dictated by the pressure difference across the vascular equator and also the volume disturbances across the vascular equator. Now, having understood that, to understand FGR in monochorionic pregnancies, you need to understand three basic concepts. The first concept is fetoplacental discordance, the second one being rescue transfusion, and the third one being collision point. Let's go through these one by one. So what is fetoplacental discordance? Here it basically means that the fetus is small, but the placenta is much smaller than the fetus. The placenta is very, very small, and the baby, for some reason, is growing beyond the means of that placenta. Now, why does that happen? We know that the placental share is less, and the baby should be small, but this baby is small, but it's still growing. And how is it growing? It is growing because of blood flowing in from the opposite side. As I told you before, arterioarterial anastomosis transfers blood from the larger share of the placenta into the smaller side of the placenta and perfuses the smaller side and allows the smaller baby to grow. And that is what is called as rescue transfusion. Now, what is the importance of rescue transfusion? How is it clinically significant for us? Let us assume you're looking at a singleton pregnancy, and in that singleton pregnancy, you find that the baby is small and the umbilical artery is showing absent end diastolic flow. So when you see an absent end diastolic flow within the umbilical artery of a singleton pregnancy, you know that that baby has got maybe around 3 to 4 weeks before it goes into DV reversal and finally fetal demise. On the other hand, in a monochorionic pregnancy, if you find that there is an absent end diastolic flow within the umbilical artery, the time that it takes to progress to DV reversal or fetal demise is not going to be 3 weeks, is going to be as long as 11 weeks. And that is because of this rescue transfusion. Now, how does that help us clinically? If you see a 21-weeker and if you find that baby has got absent end diastolic flow in the umbilical artery and it is a part of a monochorionic pregnancy, and if you know that if you've got 11 weeks, and if you do the math, 21 plus 11, what does that mean? It means that you're going to safely go into the period of viability. And therefore, rescue transfusion tells us that a small baby with an abnormality within the umbilical artery in a setting or in a background of monochorionicity has a good chance of surviving till around 30 or 32 weeks. But this is a double-edged sword. Why is this a double-edged sword? The double-edged sword is because if one baby dies, this rescue transfusion, which was actually working to help the small baby, is going to drain out all the blood from the larger baby and create either death or neurological damage in the survivor. And that risk is around 25 to 30%. And therefore, even though rescue transfusion is useful and does help the smaller baby to grow, there is a huge risk of the smaller baby dying. And when that baby dies, there can be flow of blood from the opposite side into the dead fetus, creating problems for the survivor. There is one more point that I have to talk about, and that is collision point. But I'm going to keep that for a few slides later, and you will know why. So the basic outline after understanding these basics is to understand how to screen for FGR, how do we make our diagnosis of FGR, and how do we manage FGR in a setting of monochorionicity. When it comes to screening, we are basically looking at two things. One is difference in size, and obviously if there are markers for unequal placental sharing. So difference in size is obvious. You look at CRL discordance, and when you look for signs of unequal sharing, you look at the cord insertions. So if you have a CRL discordance of greater than 10%, there is a threefold increased risk of possible SFGR in that monochorionic pregnancy. But before that, of course, you have to rule out anomalies. And if you find that the cord insertions are far apart, if you find that one of the fetuses got a marginal cord insertion or a filamentous cord insertion, then the risk of FGR is going to be significantly higher, because indirectly it tells us that the share of placenta is not going to be equal. Once you have screened them in the first trimester, you would still follow them up on a fortnightly basis from 16 weeks onwards, using again singleton charts and doing Doppler in each and every one of your visits. And you would make the diagnosis of FGR based on the same Delphi consensus criteria that I talked about. An additional criteria that would come for monochorionics would be an abdominal circumference less than the 10th centile. And here, if you have any three of the four contributory criteria, you would classify them as FGR. So the only difference here is the added criteria of an AC being less than the 10th centile, which can be used on its own alone. Now, once you have made the diagnosis of FGR in a monochorionic pregnancy, the next step is to classify them. And when we classify them, we use the flow within the umbilical artery to decide what type of FGR we are dealing with. Now, why do we look at the flow within the umbilical artery? Let me give you an example that I've always used, and that is this. If you have tried blowing air into a balloon, you would have noticed that if the balloon is thin and elastic and big, it would be easier to blow air into it. On the other hand, if that balloon is hard and small, you would have to use a lot of energy to blow air into that balloon. Okay? Now imagine a placenta. Okay? If that placenta is small, if the share of that placenta is small, will the baby need to do more work to push its blood volume into that small placenta? Obviously, yes. So if the baby has to do more work to push blood into that placenta, it is going to affect what? Its cardiac output. So as the share of the placenta keeps on decreasing, the effort done by the heart keeps on increasing. And when the heart has to exert a lot of pressure to push blood into that small placenta, which part of the cardiac cycle is going to show you that increased effort? It is the diastolic part of the cardiac cycle. And so when the diastolic flow within the umbilical artery disappears, it tells us that the share of the placenta is less. And that's why, in spite of having a good placenta, you get absent end diastolic flow within the umbilical artery of the smaller fetus. So when you classify into different types, we're actually looking at what? We're looking at the share of the placenta. Type 1 has got better share of placenta than type 2 because the effort done by the fetus to push blood into the umbilical artery and into that placenta is not high enough to cause the diastolic flow to disappear. Whereas in type 2, the amount of effort done by the heart is very high, and during diastole, the heart is unable to push blood into that small placenta, and so you get type 2. But what about type 3? Type 3 does not fit into this, right? And that's where we need to talk about collision point, and I'll tell you that shortly. But let's look at type 1 and type 2. So in type 1, we know that the share of placenta is less, but not so less to cause the diastolic flow in the umbilical artery to disappear. It is less, yes, and therefore the baby is small. But because this placental share is reasonably good, these fetuses do extremely well. They have an intact survival of close to 98%. The chance of unexpected fetal demise is less than 3.1%, and only a quarter of them will progress to type 2. And why do they progress to type 2? Because after a long period of time, the effort that has been taken to push blood into that small placenta finally affects the heart and causes the diastolic flow to disappear. There is another entity in type 1 which is called as late onset FGR. Now, here smallness starts pretty late, somewhere around 26 weeks. There are some papers that say you should look at 24 weeks as your cutoff, but I prefer to use 26 weeks because then alone this theory works beautifully. So, why do few fetuses growth restrict after 26 weeks? Now, this could be due to two reasons. One, yes, the placental share might not be that bad enough to cause a growth restriction early, but along with that, there could be a small AV anastomosis which is taking blood into the opposite direction and taking away nutrients from the smaller baby, causing that baby to growth restrict only after 26 weeks. And that is why in this group, there is a high incidence of twin anemia polycythemia sequence because along with nutrients, it is also going to take hemoglobin, creating a hemoglobin difference in these two fetuses, but not significant enough to cause TTTS. And this entity has got poor prognosis if it is associated with twin anemia polycythemia sequence. Now, in type 2, as I told you, the share is less. The heart is doing a lot of work, and therefore the diastolic flow within the umbilical artery disappears. And because it disappears, and because of the effort done by this baby to push blood into that small placenta, the outcomes are not that great. 83% of them could have a good outcome, but around 16.6% of them could die inside the uterus. And therefore, this group needs to be watched very, very carefully. Now, let's come to type 3. I said type 3 was a bit of a conundrum. If the share was less, the placental flow should be completely abnormal. But here we are finding intermittent absent and intermittent reversing, which means in between the placental circulation is becoming completely normal. And why is that happening? Now, for that, I need you to understand that, as I told you right at the beginning, the arterial anastomosis takes blood in both directions, and the blood flow is governed by the size of the vessel and also the volume of blood on either side, which indirectly means the share of the placenta. Now, let's assume that the blood volume is the same on either side, or the share of the placenta is the same on either side. What would happen to the blood flowing within this arterial anastomosis? Blood will come from one side, that is fetus A, and blood will come from the other side, that is fetus B, and they would meet somewhere in the middle of the placenta. And that would be your collision point, which means if the placental share is the same on either side, the meeting point of blood flow from one fetus and the other would be in the center of the placenta. But what if this baby had a smaller placental share? Now, if that baby had a smaller placental share, the volume of blood is going to be less on that side, and therefore, blood from the opposite side will push the fetal blood into the opposite side, causing the collision point to shift towards the side of the smaller baby. But it would still remain within the placenta. And that's what happens in type 2. But if that arterial anastomosis is large, and if the share of placenta is very less, the collision point is going to travel all the way into the side of the smaller baby, into the umbilical artery of the smaller baby. So now the collision point is not in the placenta, but is within the umbilical artery of the smaller fetus. Now, when that happens, what do you think is going to happen within the umbilical artery of the smaller fetus? All these pressure fluctuations, which we could not have seen, which was happening within the placenta, is now visible to us, and we can see it in the umbilical artery. And that is exactly what happens in type 3. In type 3, the share of the placenta is the least, and the arterial anastomosis pushes the collision point all the way into the side of the smaller fetus and shows the abnormalities of pressure fluctuation that should have been happening inside the placenta in the umbilical vessels of the fetus. So type 3 has the least share of placenta, and that is why it is the most dangerous variety, because the placental share is very, very less, and it is highly prone to the pressure fluctuations that are happening within the arterial anastomosis. And therefore, naturally, the survival rate is the least for type 3, and there is a high chance of unpredictable fetal demise as high as around 13.2%. Now, let me show you an example and show you how easily this can be missed. Now, this is a fetus, and this is a pregnancy that was referred to us with SFGR, monochorionic pregnancy. You can see that the liquor is less on one side, one baby is smaller than the other, and it was classified as SFGR type 2. And it is obvious that the umbilical artery is showing persistent absent end diastolic flow. And this is showing persistent absent end diastolic flow because the sample has been taken on the free loop. The collision point can never be seen on the free loop. If you want to see the collision point, you have to look at the cord insertion, on the placental site of the cord insertion, and you would see, what are you seeing here? You would see the blood flow changing color, telling us that you're looking at intermittent absent or intermittent reversal. So unlike common teaching that tells us to look at the free loop of the umbilical cord while doing your Doppler assessment, in monochorionic pregnancies, you have to look at the placental insertion site to rule out SFGR type 3. Now, it's important to understand that these pressure fluctuations may cause damage without death, which means the pressure fluctuations can be sometimes significant enough to cause a neurological damage, which might not lead to demise, and therefore the outcomes are significantly poorer in this group of fetuses. And that's what was shown in this particular paper. So the pointers to remember while doing your Doppler assessment in monochorionic pregnancies is that yes, you can assess the free loop first, but never forget to look at the placental insertion site. And always remember to look at the MCA-PSV because late onset growth restriction will have associated twin anemia polycythemia sequence as well. And while looking at your umbilical artery trace, remember to keep your sweep speed slow because you need a larger number of waveforms to actually pick up these Doppler abnormalities. Because when you have a larger set of waveforms, that is when you will be able to pick up these abnormalities which would otherwise go totally missed. Another thing to be aware of is that sometimes you can have TTTS along with SFGR. Now here in this particular scenario, it's an easy diagnosis to make because you're basically looking at polyhydramnios. So if polyhydramnios is present, obviously you're looking at TTTS, and if not, you're looking at SFGR. And if you're looking at SFGR complicated with TTTS, it is managed as TTTS and not SFGR. But that is a whole different talk and I'm not going to go there. Now, when you talk about management in SFGR, our primary aim is to prevent single intrauterine fetal demise. We don't want the small baby to die. Unlike in dichorionic pregnancies where we're not worried about the smaller baby dying, but here we don't want the smaller baby to die at any cost because if that baby dies, we would definitely be dealing with probable neurological damage and demise of the healthy fetus. And we also don't want to do unnecessary preterm birth. We don't want to take these babies out very early and thereby jeopardize their chance of survival. So, how do we do that? There are two basic tools that we use. One is obviously Doppler, and the other one is your biophysical profile and CTG that you should start using from around 30 weeks. The options that are available to us are either to go in for preterm delivery or to go in for selective reduction and decide to reduce one baby that is small, or go in for expectant management. So, how do we decide which treatment modality to use for which fetus? In type 1, the question is pretty answered on its own, because you know that these babies have got a good share of placenta. You just need to put them on weekly surveillance. They will do extremely well, and you would have to deliver them by around 34 to 35 weeks. In type 2, you have two options. You can either go in for expectant management, or you can decide to do selective termination of the smaller fetus. Now, here I want you to remember what I told you right at the beginning. You have a long latency period in monochorionic pregnancies. You have around 11 weeks from the time that you make the diagnosis of SFGR with absent end diastolic flow. Usually, it starts to worsen after 30 weeks, which means reasonably these babies could reach 30 to 32 weeks and you would be able to deliver both these fetuses comfortably. But if you find that the smaller baby will not survive till that period, or if you find that the smaller fetus may succumb before the period of viability, then you have to take the decision of selective termination of the smaller fetus. So, what are the pointers that will tell us that the smaller baby will not survive? There are three basic criteria that we look at. The gestational age at which discordance develops. So, if it develops before 24 weeks, with a severe discordance of greater than 35% and a severe Doppler abnormality like a reversed end diastolic flow with or without a high DVPI, then these are the fetuses that would most likely not reach the period of viability, and therefore it would be more sensible to go ahead and do a selective termination of the smaller fetus. But if none of these criteria are met, then you would advise expectant management, and you would manage your case or your monochorionic pregnancy based on the Doppler findings of both these fetuses, but primarily the smaller baby. And if you find that the ductus venosus of the smaller baby reverses before the period of viability, then you again talk about the option of selective termination. If that does not happen, and if the DV remains normal and you cross the period of viability, you can take these babies and try for preterm delivery and try to save them both. So, in a nutshell, before 28 weeks, if you find that the DV flow is absent or beginning to reverse, then you could think of selective termination of that smaller fetus. But after 28 weeks, you would decide to go for preterm delivery based on the same singleton criteria that we have been using, that is, persistent reversed end diastolic flow, or an abnormal biophysical profile, or an abnormal CTG that should prompt preterm delivery. But what about type 3? Now, in type 3, there is a unique problem. And the problem here is that the ductus venosus is not going to reverse. And why the ductus venosus does not reverse is because this heart is not under continuous strain. This heart is experiencing intermittent periods of increased strain with intermittent periods of extremely good flow. And because of that, this heart will not fail like the heart of a SFGR type 2 fetus. And therefore, in type 3, if we wait for the DV to become abnormal, it might not work. And therefore, in these fetuses, the exact criteria is still suspect. We still do not know on how to follow up these fetuses, but we would definitely advise elective delivery of all these fetuses by 32 weeks, irrespective of the condition of the Doppler that you find. So in type 3, you would go for elective delivery of all these fetuses, irrespective of their Doppler condition, at around 32 weeks. Now, if you decide to do selective termination, there are two options that are available for you. One is a bipolar cord coagulation, or to do a radiofrequency ablation. I'm not going to go into the details of this, but basically in bipolar cord coagulation, we just grasp a cord and burn the entire section of the cord and thereby cut off the blood supply entirely so that there is no communication with the AGA fetus. And the AGA fetus is saved from the abnormal hypoperfusion that could happen if blood goes into the dead fetus. The other option, which is the most popular option nowadays, is radiofrequency ablation, where we put a needle into the liver of the smaller fetus and ablate the vessels that enter into the liver and thereby cut off the blood supply with that of the larger fetus. So to sum up, in monochorionic pregnancies, when we see CRL discordance or abnormally placed cord insertions, we should suspect the possibility of SFGR. We should follow up these fetuses on a fortnightly basis with both growth and Doppler, and do not forget to look at your MCA PSV, and always remember to look at the umbilical artery trace next to the placental site. Classifying SFGR into types tells us about the share of the placenta. Type 1 having a better share than type 2, and type 3 having the least placental share. For uncomplicated type 2 and type 3, that is the ones that do not have DV reversal or severe discordance or that develop discordance before 34 weeks, you can go in 24 weeks, you can go in for expectant management. For the rest, you should think about the possibility of selective termination. So to end, twins, yes, is definitely a cause of concern, but you should always think that there is no thing called as good news or bad news. There's just news, and we should learn to manage it. Thank you so much for listening.
Thank you very much, Dr. Bijoy, for telling us about the physiology, the scientific basis, how the Doppler changes occur. We normally, we read that the Doppler is going to be like this and going to be like that, but we don't understand why it is like that. So I would request chairpersons to please give their comments and any other thing. Dr. Manju, please.
Dr. Vijay, you were really very crisp and to the point, right? But I have one doubt, I was also reading, in 2024, this Khalil and Nicolaites they've given. So they said, two criteria, the Delphi consensus says that, one was just less than third percentile. And out of the four, any two criteria. But they never mentioned that, dichorionic is separate from the monochorionic. But you, in dichorionic, you said out of three, one, and other side, less than third percentile was there. But in monochorionic, you said, you included all those four. Why this difference? I mean, are you using some other criteria for some this 2024 article?
I hope I'm audible. You were breaking in between, but I understood the gist of the question. It is the dichorionic criteria are different from monochorionic in the sense that only one extra parameter is added in the contributory criteria. So in dichorionic pregnancies, you need 2 out of 3 criteria, whereas in monochorionics, you need 3 out of 4 criteria. So the addition of an extra criteria is probably to increase our sensitivity in picking up these babies that are small. That's all. In dichorionic pregnancies, the smallness need not be that closely monitored because we're not very worried about that smallness affecting the AGA baby as much as the smallness in a monochorionic pregnancy. But the diagnostic criteria has always been different right from the start, both for dichorionic and monochorionic. The initial paper that came out came separately for dichorionics and monochorionics. They studied them separately, and the criteria have always been different.
Sir, I just wanted to ask.
Yes, ma'am.
After
Dr.
selective
Vandana.
reduction, aren't we putting the baby, the living baby at risk for neurodevelopmental disorders?
No, the reason why we do reduction is when we are forced to do it, because the smaller baby would die before the period of viability, and that would put the larger baby at risk, around 25 to 30% risk of demise or neurological damage. Now, when we do a RFA or a bipolar cord coagulation, we are not saying that the chance of neurological damage is going to be 0. It is going to be less than 10%, much less than what would have happened if that baby died physiologically. And the success rate of RFA is now above 90%, and the probability of having a neurological damage or death in the survivor is extremely low. And that is a risk we have to take in that setting.
Dr. Bijoy, I presume, when you are doing fetoscopy, bipolar coagulation, you're doing fetoscopy. Am I right or wrong?
No, it's
Not
ultrasound
necessarily.
guided. Ultrasound guided. Yeah. Fetoscopic laser is used as a treatment modality in SFGR, but the problem is it is not successful for two reasons. One, there is no polyhydramnios in the sac of the fetus, the AGA fetus. And second, when we do a dichorionization, obviously we are going to create a problem for the smaller baby. The share of that baby's placenta is extremely low, so in the process, we're going to lose out on that smaller baby. And therefore, here the treatment modality is always selective termination. Although some centers do advocate to go in and try to save both the fetuses by doing a fetoscopy, but our take on that is to go in for selective reduction.
So long time back, Dr. Bijoy, when we didn't have many fetal medicine people, we were relying on the radiologist to do this, all these things were unheard of, So your management is as good as your fetal medicine person. That's what I presume in today's scenario. So in pregnancy, if at all I have to do an ultrasound now, I only send them to fetal medicine person. I think that is the one message I want to give to all the juniors who are listening, It's much better, at least 12-week scan, 20-week scan or early anomaly scan should be done by a fetal medicine specialist rather than by doing it by a radiologist. And another question which I have in mind, you said collision point. Is it some hypothetical point, or you can actually pick up this is the collision point in ultrasound?
No, it's a hypothetical point that tells you the point where these two blood streams meet. We cannot actually see it, but that meeting point is the reason why we get this sort of a Doppler pattern in type 3 FGR.
It is basically explaining the pathogenesis, so that we can understand why the waveforms are like that. So, Dr. Suchita, would you like to add
Yeah.
anything?
Thank you, sir, for a wonderful talk on FGR in twins and explaining when to deliver, which is the most common dilemma I feel in cases, especially in monochorionic twins when we have Doppler abnormalities. I think it was very, very explanatory, and I've nothing to add to it. Sir has almost covered everything, I feel.
So I don't see any questions in the chat box. So if anybody wants to ask anything, please write your query in the chat box. The Dr. Vijay, the problem in here, what I face is that people would like to is in dichorionic twins. They do not want a premature delivery. So they would rather sacrifice the baby which is small and let the other one go to term. Because they feel that a premature baby, you don't know the survival, you do not know the CNS intactness. So that is another thing which is an option.
Yes. It is definitely an option, but the problem here is for sometimes the smaller baby might also survive till around 36 or 37 weeks, and you might get a severely handicapped child at the end of it, as was shown in that paper by Neil Sabir, where they had, I think, two babies, one with blindness and one with cerebral palsy. So that is a difficult decision to take, but yes, it's entirely a decision that the parents
So
should
it's very important, I think, to counsel really and
Yes.
to see how.
Yes.
And here the counseling would not help. The patient would say, "Aap decide karo." Now, what do you decide?
No,
They
that is
will
the
mention
art
this
of
or take a
counseling.
call.
No,
I think
that is
that's
the
why
art of counseling. You have to tell them, you sometimes spend 1 hour counseling. Then only they never take the decision for them. They would have, it's
See,
always
that's perfectly okay. That's perfectly okay. But if things go well, they are happy. But if things go hunky-dory, then the blame is all on you.
you have to write it. Keep it in writing.
आपने कहा था ठीक हो जाएगा. That is a
But good thing is, about in these cases, that as compared to singleton, latency period is good. So by and large, you are able to reach, 32, 33 weeks, and at least the survival is good,
35 weeks on an average, we can take a call.
Yes.
35 would be fair enough.
Centers, they still do not like to have a 30-weeker or a 32-weeker.
Yes.
30-weeker
And especially the normal one.
Okay.
Yeah.
Our take is basically how we manage is that if we have an FGR in DC twins, at 30 weeks we do counsel them about the possibility of saving both the babies. And because we work primarily in an IVF center, we have found that most of the parents are open to that idea because they understand that there is a good chance they could get both the babies. But on the other hand,
Both.
we find that the smaller baby is very bad, and we tell them that at 30 weeks, the baby is already in DV reversal with aseptic regurgitation and things like that. We would tell them that this child might not survive beyond a week, so might as well continue the pregnancy. So always depends on the
Yes.
case as well.
Yeah.
Yes.
The idea is to understand what cutoffs we should follow so that we have a basic guideline to understand beyond this we shouldn't wait, or beyond this we can wait, and this is the right way to move forward. So I think that's what's more important. Each case has to be taken on its own merit, actually.
Yes. Yes,
Yes.
absolutely.
Yes.
So should we close it if there is
I
no more
don't
question?
see any questions. Oh,
Okay.
I think there is one question. If we find an abnormality which has bad prognosis, like HLHS, obstetricians force fetal medicine specialist to write termination of pregnancy. Can we write?
I think termination of
That's
pregnancy is the
Never.
choice of the parent.
Never. It can be.
We can tell them about the prognosis. So if there is
prognosis.
fetus, this is what is going to happen. This is the problems with surgery, postnatal care, and all those things, and then they have to take a call. Whatever the abnormality, we counsel them about the prognosis, and based on the
Yes.
prognosis, they have to take their decision.
I think this is not about twins.
Yeah, I think this is about singletons.
This is about
Singleton.
singletons, yeah. So,
Okay.
Dr. Sharad Gupta, I think it's very simple that, we cannot force anybody. Nobody can force us
Anybody
to
can
write.
take it.
Yeah,
No.
but of course, we can write, may consider
May
termination of
consider.
pregnancy
Yes, ma'am.
if it is a very bad prognosis. And rest is left to the legal issues. No, here, termination of pregnancy is sometimes quite easy before 20 weeks. After
Yes.
that, anyway, the medical board will
Board
take
will
over
take
after 24 weeks.
After 24 years.
So I
Yes.
think we had a very nice discussion.
Brilliant.
Yes.
Anything else anybody wants to add?
No, thanks.
Otherwise,
No,
it
ma'am.
is, I would really like to thank you. And
Thank you.
Anaya, are you there? Yeah. And thank all the chairpersons for giving us your learned
Thank you.
opinions.
It was a great learning
Thank you.
experience. Yeah.
Thank you, Dr.
Yes,
Deka, for
ma'am.
inviting us. I mean, it was really very good to listen to Dr.
Very,
Bijoy. I
very,
enjoyed it. Very crystal
Yes.
clear.
very.
Yeah. Very crisp, very clear, and very nice knowing the background of the changes in the
Changes.
Dopplers, which can make us understand what actually the pathological direction it's going. So thank you, Dr. Bijoy. We
Yes.
know that you are a great academician and you have spent so much time. Thanks a lot.
Thank you, ma'am. Thank you.
Thank you. Thank
Thank
you.
you.
And thank you all my
Thank you.
chairpersons, Dr. Manju, Dr. Vandana, Dr. Suchita, for being here.
Thank
Thank you.
Thank you, ma'am. Thank you,
Thank
Thank
sir,
you,
Bye.
everyone.
for talk.
We are
Thank
very grateful for sharing your expertise today, sir. And very special thank you to all our attendees for joining us today and contributing to this important conversation. Thank you all once again for being here. Have
Yes,
a
thank
great
you all the
day.
participants, but I'm surprised that there were no questions.
Right.
The twins, I thought, would have a very heated, discussion.
No,
Yes,
Deka, this
ma'am.
is a very rarely encountered topic by a normal obstetrician.
Yes,
Yes, ma'am.
that's why.
So that's why there were less queries.
Abhi, it's
No, I
taking
thought
time to
obstetricians
sink in.
have to manage. Nowadays, we are seeing more and more of twins.
Right.
So many twins, ma'am. Because of the IVF
Yes,
pregnancies, so
because
many
of that.
twins.
And that's why they're even more precious.
Yes.
So, they want to get both the babies instead of just one.
Yes, ma'am.
Not
Yeah.
only if the parents want both the babies.
Yeah, that's what, no?
Yeah.
Thank you very much, Deka. I'll take leave.
Thank you,
Okay,
Time for
ma'am.
my opening.
thanks.
Bye-bye.
Thanks,
Bye.
Manju. I hope you
Bye.
got the letter from Nina regarding the Amazonian meat.
No,
I'll
I
send
haven't
you.
got.
I'll send you. I have also sent you. Please come.
Okay. Right. Bye-bye.
Okay, bye.
Thank you, ma'am.